Greetings, I'm Dr. Kim Yong-jin. In this online master course, I'm going to address complications related to sinus lift using Crestal approach. As shown in the list, there are many complications when you do sinus lift using Crestal approach. Most of them would be intraoperative complication. In the case of a post-operative complication, this will be addressed at a future master course. Today, I'm going to talk about when it is difficult to get the primary stability and when there is a sinus membrane perforation. I'm going to address these two topics primarily. I believe these two complications are what we come across most frequently. Let's look at primary stability failure. This can occur at times. In most cases, upper posterior areas bone quality is soft, and the fact that you require Crestal approach is that there is lack of residual bone and the bone quality is poor. It is difficult to get primary stability under those conditions. In order to prevent it, you need to do underdrilling. Even if you have successfully penetrated the sinus floor in a safe manner using CAS kit and placed an implant, if the bone quality below sinus floor is poor, then you may not get good primary stability. That's why you need to have TS3, ultra-wide 6.0 and 7.0 millimeter implant along with 5.0. If the bone quality is anticipated to be poor, then you need to use implants like TS4, which has larger taper compared with TS3. It has larger taper and the thread depth is deeper. Therefore, this implant system is dedicated for softer bone situations. Also, you need to do underdrilling. Even if you use CAS kit, which is frequently used in Crestal approach, if the bone quality is anticipated to be poor, then you need to do underdrilling even with CAS kit. Despite all these efforts, what shall we do if the primary stability isn't good? If we do not have sufficient primary stability, then we will not be able to block out possibility of micromotion, and you will not be able to get a successful osseointegration. If the primary stability is too low, some people use cover screw and submerge it, but I think it is better to get at least 15 newtons of primary stability. That is my recommendation. As a result, you end up using rescue implant, which is wide diameter implant. Yes, primary stability may not be good. Even then, in those cases, it is better to do submerging. In the past, inlay bone graft was performed. Autograft was harvested from tuberosity or other sites, and it would be placed between implant and drilling site. By doing this, the goal was to get better primary stability, but this is no longer used. TS3, 6.0 and 7.0 diameter implants need to be prepared. As mentioned earlier, compared with TS3, it has a more aggressive taper. This is TS4 ultra-wide implant. It has 6-degree taper. In the case of TS3, it is 1.5 degree. If you are going to use ultra-wide diameter, I prefer TS4 over TS3. Let's look at the diameter on the apex side. Even in the case of diameter 6 millimeter implants, TS4 has smaller apex compared with TS3. After removing 5.0 implant without doing additional drilling, you can place 6.0 millimeter TS4 implant. Therefore, I prefer TS4 ultra-wide implants. The next complication we're going to look at is sinus membrane perforation. There are sinus lift dedicated surgery kits like a CAS kit fit for Crestal approach, but Crestal approach in itself is blind surgery. Therefore, you can experience sinus membrane perforation clinically. Let me explain by looking at a case. So when we used OSSTEM in the past, the sinus membrane perforation occurred very frequently. As shown, at the moment of fracture, the margin of sinus floor is not really clean. Therefore, if the membrane thickness is thin, then perforation can occur. Additionally, perforation can occur as bone graft is grafted using osteotome. Such has been reported by many researchers. Currently, we use casket from OSSTEM very frequently, therefore, the possibility of membrane perforation has gone down significantly. However, inevitably, at times you can experience membrane perforation. As shown, whether you use osteotome or casket, small perforations can occur. The way to check perforation is to have the patient hold their nose and breathe in and out. This is the Valsalva maneuver. You can check sinus membrane perforation using this. In most cases, sinus membrane perforation is avoidable, but at times it inevitably occurs. There are many risk factors. The patient's membrane can be very thin, and there can be error in residual bone height measurement. Depth needs to be shorter by 1 or 2 millimeters compared with sinus floor, but at times measurement can be wrong. CT or panoramic images are used to measure residual bone height. And if drilling depths exceed sinus floor, then perforation is bound to happen. As shown, even if you do a good job in measurement, mistakes can occur. In most cases, on CT or panoramic image, we measure residual bone height using the blue line. However, if the actual drilling follows the black line, or if it is too palatal, then the height of residual bone will be different from what I've measured from CT and panoramic images. The residual bone will either be more or less. If it is more, it's not a problem, but if it is less than what is measured, in terms of controlling initial drilling depths, there can be issues. Another issue is a steeply inclined sinus floor. In this case, even though Crestal is flat, in some areas it could already be penetrated, whereas in others it may not be. If you put the depth gauge in, you can feel the hard floor. In this case, if you proceed with Crestal, the sharp lateral side can be in direct contact with the membrane and can cause unanticipated perforation. In other words, if sinus floor is flat, it will be less possible, but if inclination is steep towards buccolingual direction or mesiodistal direction, then there can be risks. When you utilize a septum area, because of the septum, you may not be fully aware of sinus floor penetration. In that case, as you proceed, then membrane perforation can occur. The way to check sinus membrane perforation is to do a Valsalva maneuver where the patient holds nose and breathe. There's a sinus membrane perforation if the patient says there's some sort of wind or if there's air bubbles. When you check a sinus membrane perforation using Valsalva maneuver, you cannot repeat a strong Valsalva maneuver. Crestal approach is blind surgery, and we cannot anticipate the thickness of sinus membrane, and if you have the patient repeat the strong Valsalva maneuver over and over again, iatrogenically, a sinus membrane can be perforated. You need to do it either once or twice and check. The most important thing when you notice sinus membrane perforation during Crestal approach is not to do bone graft. If you're not going to transition to lateral approach, the principle is not to do bone graft. Some people have the illusion that the sinus membrane can be repaired by using a membrane and bone graft material into the small drilling hole that has been made through Crestal approach. That by doing this, membrane can be repaired, but this is actually impossible. You cannot detach membrane accurately in this case, and if sinus membrane repair does not work out, then bone graft material can go into the sinus, causing post-operative infection, or in other words, sinusitis. When you're doing Crestal approach and if there's sinus membrane perforation, you need to look at accurate height of residual bone. If the height of residual bone is over 6 millimeters, don't do grafting, just to use a short but wide implant. In order to compensate for shortened length, you need to increase the diameter. From implant top, the stress is delivered up to 5 to 6 millimeters. Therefore, if the height of residual bone is over 6 millimeter, it will not be transferred to below. In that case, I use a short but wide implant for replacement. If the residual bone height is less than 5 millimeter, then you need to augment bone so that there is 6 millimeter of distance from implant top. In this case, if you're going to do bone graft, you need to transition to lateral approach and accurately repair the perforated membrane area and do bone graft. If you do not agree to lateral approach, or if the patient declines, then you need to wait about 8 weeks to 12 weeks, in other words 2 months to 3 months after just closing flap. Then a membrane will heal itself. Putting collagen plug through the drilling hole may help, but I do not really prefer that. By just closing the flap, because the drill hole size itself is small, healing occurs easily. In summary, if the height of residual bone is less than 4 to 5 millimeter, you need to transition to lateral approach. Repair the membrane, do the bone graft, and place the implant, or else you need to wait 2 to 3 months.
그래프트를 하시고 임플란트를 식립하셔야 될 것이고요. 그렇지 않으신다면 2-3개월 기다리는 것을 추천드립니다.
During Crestal approach, in number 7 area, membrane perforation has occurred. In number 27, in order to place the implant on the day, lateral window was formed and the perforated area was isolated accurately. By using collagen membrane, you can seal the perforated area. Let me share with you a case. Number 24, 25, 26, and 27. 4 implants were to be placed. The residual bone height was measured to be 4 to 5 millimeters pre-op, and casket was used for Crestal approach. I've mentioned before that there can be unanticipated circumstances. If you take a look over here in number 27, due to severe periodontal disease up to the apex area, perio disease is spread. Because of that, there's erosion of sinus floor, there's resorption, and because of periodontal disease, granulation tissue has been formed and adhesion with sinus membrane occurred. As shown on sinus floor, there's loss observed, and there's adhesion between sinus membrane and granulation tissue. This is very difficult to detach. And in this circumstance, if you use Crestal, because there's no bone base, sinus membrane can be perforated. Partial perforation can be made very easily. Number 27 was extracted. Number 24, 5, 6, and 7 4 implants were planned. This is pre-op situation. As shown on this image, there was very severe exostosis. This can be used as autogenous graft. You can trim it and use it along with torse. You can either use bone ronger or ossenbein chisel. You can trim it, and using bone crusher, you can use it as autogenous bone graft material. The area where sinus floor is lowest in number 26, sinus floor penetration was done and hydrolift was planned. In number 27, while we were doing hydrolift to penetrate the sinus floor, the saline used did not come out. It didn't come out. I checked it with Valsalva maneuver. In the area where there was adhesion, there was microperforation. If the size of perforation is small, perhaps you may think that it's okay to put in bone graft material. However, the extent of perforation can increase as we do bone grafting, and the bone graft material should not go into the sinus, and therefore you need to do repair accurately and then proceed with bone graft. As shown, vertical incision was done, lateral window was formed. After that, I've used the bone graft material here, which I've gained by removing the exostosis, and I've used the bone crusher to make it as bone graft material. If I just use autogenous bone graft, there can be severe resorption and there's not enough quantity. So I've mixed it with OSSTEM's QOS Plus, which is alloplastic material. The autogenous bone graft material from Bone Crusher and QOS Plus, HA and beta TCP is mixed within QOS Plus. Sinus membrane is detached in the perforated area. One collagen membrane is applied and it is perfectly sealed. QoS Plus and autogenous bone graft material mix is applied. And then I'm repositioning the lateral window lid. In this state, implants have been placed in number 6 and 7. In number 7, around the existing teeth, there was very severe periodontal disease. There was very severe bone defect and bone quality was not very good. 5.0 diameter implant was not sufficient to get primary stability. Therefore, I've used TS4, an implant with a 6-degree taper, and I've used a 6.0 diameter, which is ultra-wide diameter implant. As for the rest, I've used a TS3 to restore the site as shown on the mesial side. TS3 4.0 diameter, and in number 6 5.0, in number 7 TS4 6.0 diameter implant was used. If you use TS4, you can get much better primary stability. By doing this, I've used a healing abutment and completed the surgery in one stage. This is post-op panoramic image and PA. If you look at CT, because of membrane perforation, you can see bleeding around the membrane. However, membrane has been detached accurately and I found the perforated area and sealed it and then proceeded with bone graft. The bone graft form shows ideal dome shape. I've mixed autogenous bone graft with alloplastic, which is very slow to resorb. By doing this, you can get good new bone regeneration while maintaining volume. At post-op 3 months, to fabricate final prosthesis, transfer impression coping is used to take implant level impression. This is at 3.5 months and final prosthesis was delivered. This is at occlusal view. This is panoramic image after final prosthesis delivery. As shown, because I've used alloplastic, which is slow to resorb, below the sinus membrane you can see the bone graft material being maintained without resorption. This is 1-year follow-up as shown. You can see below the lifted sinus membrane, new bone formation is being done nicely. This is 3-year follow-up. You can see that it has progressed. If I had only used autogenous bone, the resorption would have occurred up to apex area, but because I've also mixed it with QoS Plus, which is alloplastic, it is well maintained. This is 4th-year follow-up. You can see ossification has progressed even more. This is a CT follow-up. This is at 4 years. In number 7, where perforation occurred, once repair is done, the bone graft material doesn't go in the sinus, and before the collagen membrane is resorbed, it maintains the lifted sinus membrane and a nice environment for ossification is formed. Let's look at panoramic image in chronological order. At 1 year post-op, it is well maintained, and at 3rd year, ossification has progressed, but there's no change in volume. You can see that it's well maintained up to 4th year. This is right after surgery, and this is CT after 4 years. Right after surgery, this is bone graft here, and at 4th year, as ossification occurs, there's no change in volume and is well maintained. If you look at the CT, there's no pathologic symptoms or symptoms of sinusitis. This is number 7, right after surgery, and you can see that it's well maintained. If you are hesitant about doing this, and if the patient is not willing to accept various complications such as excessive swelling after surgery, after doing lateral approach, or if the patient has certain issues medically, you need to delay the surgery and attempt the Crestal approach later. In that case, without taking additional measures, close the flap and wait 3 months. After that, you can do re-entry. As mentioned earlier, in the case of membrane perforation during Crestal approach, if you do not transition to lateral approach and just use the small drill hole to push in the membrane and add bone graft, and some people actually think this works, Regardless of whether you use osteotome or Crestal after membrane is perforated, some people think that it is okay to use collagen membrane and bone graft material to fix the situation, but this is a big no-no.
만들 수 있을 거라고 말씀하시는 거나 생각하시는 원장님들도 계십니다. 하지만 절대 이렇게 하시면 안 됩니다. 왜냐하면
Because this bone graft material will not receive blood supply. What we need to consider is that although you may be able to push in bone graft material to the same level, the level of bone regeneration between these two situations differs significantly. You may think that bone graft material may turn into bone, but that is not true. Bone graft material serves as a scaffold material, and if there is no blood supply or osteoblast supply into the bone graft material, then ossification will not occur. In other words, contact with the inner surface of sinus needs to be available. Stable ossification of bone graft material can be achieved only when there is sufficient contact with residual bone within sinus. Although the height of bone graft material may look similar on panoramic images, the prognosis of bone regeneration may differ significantly. Bone grafted area should be at least in contact with 3 bony walls. This will lead to ideal ossification of bone graft material within the sinus. What people say may ring true if people use osteoinductive material such as autogenous bone graft material rich with cancellous bone. In most cases, we use osteoconductive material, which is FDBA or xenograft or alloplastic material. Therefore, it doesn't work. It just remains as bone graft material. This sort of situation results. If the bone graft material is not saturated in blood or does not have contact with residual bone, it just remains as bone graft material. Will these be of help in transferring occlusal force from the implant? In this case, the predictability will be unfavorable, and in extreme cases, if that area bursts, it can go into the sinus. Hence, such type of repair should be avoided.
저런 방식의 리페어는 하지 않으시는 게 좋겠습니다.
In summary, during Crestal approach, if you do not have primary stability, you need to use ultra-wide implant to rescue the situation. And during Crestal approach, if there is membrane perforation, you either need to delay the treatment or do lateral approach to accurately repair the perforated area and do graft and then place the implant. As for other complications, these will be addressed in offline master course rather than online master course. Thank you.
코스에서 자세히 말씀드리도록 하겠습니다. 감사합니다.